Okay, hello everybody. My name is Cristian Manea. I'm a urology surgeon. I'm from Romania, but now I work in France, near Swiss, Colmar, and Alsace. Okay, I and the team to prepare a score because now I saw it. We have already a score for the kidney cancer for the surgery, especially for Nephron-Sparing surgery. This is in the PADUA score. It's a score which describes the anatomy of the tumor. After that, we can know if we have any complication or which is the best way to take out the cancer, the kidney cancer, for preserving the renal unit. But we thought that only the anatomy of the tumor is not enough to avoid any complication. Why? Because we have only the vascularization of the kidney. To prepare the kidney, for save the kidney, we need the vascularization to rest there without any complication and without any injuries of level of the nephron of the kidney. That's why we try to combine this core of an anatomical tumor and the vascular aspect. I don't have a potential conflict of interest to report. First, this renal vascular segmentation was described in 1744. After 140 years, we know that the kidney particularity described with the ischemia. We know that start 1882 that arterial and the vascularization of the kidney is the type of the terminal vascularization. That means if you cut a segmental branch of the arteries, that region, we don't have after that the vascularization and the risk of necrosis and ischemia. 1901, Brodel described that the region of the kidney concerning this vascularization and describe an anterior, posterior, and the frontal. And then know that the frontal region of the kidney, the line of the Brodel, is an avascular region. That's why we can cut it frontal. For example, when we do the nephrolithotomy, when you leave the calcium and leave the lithiasis of other pathology of the kidney, this region is avascular, and we have that assurance that we don't do damage of the kidney. Later, 54, as we know today, the Grace describes that classification of the renal vascularization with the arterial, 4 anterior, 1 posterior, and we work today with this type of classification. But today, in 2022, this type of classification is very, very changed. Why? Because I think the genetical aspects change the anatomy of many, many organs, and we have a malformation, vascular malformation of the kidney. 51, the French people, the Professor Dufour, explain what it's important to know the vascularization when we do the Nephron-Sparing surgery. Why it is important to know where is the arterial, where is the venous region to prepare and save normal tissue. After that, to minimize renal ischemia, because we try to clamp the arterial artery of the tumor, but we saw it after that other mini branches, other small branches after other region of the kidney due to the vascularization, and the risk of hemorrhage goes up, and after that we clamp it, we do the ischemia. Only 42 in the study, the last study we was published for the Italian 2017, only 42 of the arterial of the vascularization of the kidney was on Graves' description in 1951. Now it's very, very changed. More than 50, 55, another region, 60% of the malformation of the vascular disease, we saw it. Now, before the surgery, we can do the three-dimensional imaging. We can printing the kidney can print the tumor, we can print the vascularization. We can do all this type of virtual models. It's better for the surgeon and it's very safe for the patient when we decide to do the Nephron-Sparing surgery. But always we have a question when we do this type of the printing, maybe in interior change very, very much the aspect we have this type of image. For example, when you do the surgery, if it starts to the hemorrhagic and we start the malformation of the graft, what's happened there? That's why we need experience of the surgeon. It's not enough this type of the three-dimensional virtual models. We have planning for the students, for example, to learn to know the anatomy. You can use this type of imaging the same in the surgery. We can do augmented reality in the surgery directly when you do the surgery on the console robotic surgery. But this type of frame many times we change it when we push the tissue, when we change the position of the kidney, when we change the position of the bowel. This type of augmented reality is not helpful, and that's why we need to do something else. We start with open surgery. Today, many centers do a lot of open surgery because the robotic surgery is expensive for many regions. And we start open surgery, and little bit today we have artificial intelligence. Okay, it's not for the robotic surgery, for example, this artificial intelligence is not completely defined because we have a problem with the artificial intelligence. Why? Because we need money for this, and we need to prepare the people to know this type of reporting on the surgery. We know we use this type of artificial intelligence, for example, to avoid to cut a lot of tissue for the kidney, to remove as little as possible surrounding of the tumor. But that's why we need this type of intelligence, deep learning networks. We have it, you use it. And after that, after the machine knows how to do it, the surgery, now, after that, it's very important to know if it's safety for the patient. If it's safety to let the machine do the surgery, to stop the surgery, to limit the activity of the surgeon. I think it's not possible for instance, maybe in the future. And we have several challenges. It's expensive, as I already told it. It's limited field of view of the interior of the surgery, because this type of augmented reality is only on the region where you do the surgery. It is impossible to saw it near the region on the left side. For example, we work in the right kidney, we don't know what's happening in the middle. We don't know what's happening in the base, on the cranial. That's why we need to change the anatomical plane. When we do the surgery, many times change the region, change the plane. Maybe if you use automated ultrasound, maybe we'll be fine. But we don't have today this type of machine. And the same when we do the coagulation in the interior, we have the smoke. We need a machine to absorb this type of smoke, to clear the field, to watch, to know that image is clear without any artifacts to do the well surgery. This type of partial nephrectomy or Nephron-Sparing surgery is a bleeding surgery many times. We cut the kidney, we cut the artery, we cut the venous aspects, and that's why it's very dangerous for the patient. It's very dangerous to save the kidney if you don't have experience. After that, when it's hemorrhagic, when we have ischemia, have alteration in hemodynamic status. We have anemia. When hemorrhagic, we change the arterial tension, change many types of hemodynamics. This type of vascular capital pedicle renal is crucial. It's very important to know which artery it's possible to cut it, which one we can leave it to continue to vascularize the kidney. It's very important to ensure efficiency and safety of renal segmentation excision. that consider the anatomy is possible of the vascular variants. It's very important to know how many arteries, how many veins we have before the start of the surgery. It's mandatory. Ischemia time is very important because when we have the ischemia, we have the necrosis. When we have the necrosis, that tissue is compromised and it doesn't work. And after that, the nephron filtration viability is not good. It doesn't work. It is important after that to take out the kidney. This type of vascularization of the kidney is very important in nephron-sparing surgery. The same in transplant surgery. The gold standard, now you use the nephron-sparing surgery and all the kidney tumor T1. That means the tumor is maximum 7 centimeters. But we can use it the same on T2 tumors, more than 7, 10 centimeters when we have one kidney, only one kidney, and when we have the kidney, the chronic kidney disease, where it's very important to keep much tissue it is possible of the kidney. The same warm ischemia time is very depends very much for the location of the tumor, the size of the tumor, and of course the variation of the vascular anatomy. It's very important before the surgery that surgeon know exactly how many artery and vein is in a pedicle. We know we have an imaging protocol, and many hospitals don't use it, but it's important to know it. If you have it, tomography, MRI, or 3D dimensional, as we described before, 3D printing to show it exactly how many arteries and the region report of the tumor. We want to correlate these vascular aspects with the tumor anatomy, like it was PADUA score, because the two together is most fragment in doing the complication of nephron-sparing surgery. We propose an original classification system using this tumor anatomy and the vascular aspects, and after that, together to know how fragmented is the incident and how many complications we can obtain after that, and define, of course, the severity of potential perioperative complication. That depends the complexity of this KAVA score and the PADUA score. Starting 2018 until 2021, we include in this study 272 patients with clinical stage of the tumor T1. All the patient we do it before the surgery, tomography or MRI. We use the renal scintigraphy only for 8 patients who have 1 kidney or the chronic kidney disease. And all the tumors were classified by the PADUA score. Surgeries were performed by 3 surgeons. We do the open surgery in 209 patients and laparoscopic robot-assisted surgery with Da Vinci SIXI 63 patients. We have the group A. We had with the normal vascular pedicle, artery vein without any branches, without any malformation on the vascular, and group B with vascular variants, and group C is the group when we do the surgery after the primary surgery, when we do to resolve the complication to the hemorrhagia and the anemia after the first surgery. We know in the studies the ischemia time it's 20 minutes, 25, other study 28, 29 minutes. We have all patient median the 22.6 minutes. We are doing the same with 0 time ischemia. Only the tumor was fixed on the exterior of the kidney. When we can possible to do it, enucleation of the tumor. We don't clamp the arteria pedicle. We let it with 0 time ischemia. We watch that with blood loss, the hemorrhagic disease bleeding, they can obtain a clinical and paraclinical response. That's why we start at least 300 milliliters. Start 300, we have the tachycardia, change the blood tension, change the parameter of laboratory test. And the severity of anemia is for 4 levels according to hemoglobin to World Health Organization classification. For us, for the study, the p-value was less 0.05 was considered statistically significant. We use the STATA version 9.1 software. And the final sample was 105 patients with variables necessary with the new study. We have a malformation, vascular malformation. And here we have the parameters we use it. We regard it from the age, gender, tumor localization, PADUA score, hemorrhagic score, anemia, pedicle ramification, all the malformation we have on region of the kidney and the KAVA and the vena cava. 109 patients, 40% using group B, 70 patients are doing the open surgery, 37 robot-assisted laparoscopy. And the group C, where the complication was 11 patients, 6 is conversion to open surgery, ligation of multiple arterial branches, and 5, we do the embolization before do the initial surgery. This depends of the quantity of blood of the hemorrhagic. After that was plus the 500, we do the open surgery. In our studies, superluminal and early branching arteries outside of renal sinus was 87 patients. Majority was the left kidneys, compared to right. The same, we have the venous variance detecting 42.5%, left and 25 right kidney, and precaval right renal artery was detected in 4.2%, and duplicate abdominal vena cava was identified in 3.6%. This factor is significant when the p-value was less than 0.05, was the PADUA score. As already know, it's very important, the anatomy of the tumor on the kidney resection, the pedicle ramification, and the precaval renal artery, because it's difficult. It's we need a complexity of the technique, the precaval arteries, because it's near the cava. And that's why the risk of injuries, the cava, it's high. The same, the impact of ischemia, hemorrhagic, and anemia on renal function is very important, was the same, change the blood tension, tachycardia, is change the quality of hemoglobin, and that's why starts to do the ischemia, and after that the necrosis. As already I told you, the ischemia, hemorrhagia, and anemia has significant impact of the deterioration of renal function, because this ischemia done some work. Ischemia is important, the p-value less the 0.001, hemorrhagia is less than 0.001, the same, and the same the anemia is statistically significant for the deterioration of renal function. Directly, indirect and systemic effect when we discuss for all of the kidney function. We can create a score to indicate the severity of the perioperative consequence, ischemia, hemorrhagia, and anemia, depending on the risk factors. I already told you the PADUA score, the tumor location, and number of arteries, the position, anatomical position of the arteries. And this score indicates the severity of the deterioration of renal function through relationship shows in another equation, the 7 to 10. The prediction, the KAVA score, assesses the severity of intra and post-operative complication. The KAVA score, together with PADUA score, is an important factor for Nephron-Sparing surgery, because when you use it, the two types of scores together, we know how difficult will be the surgery we know how we took this type of patient to perform a safe surgery. Each element of the KAVA score estimates likelihood of severe complication. The impact of the endogenous variable risk, ramification, arteries and veins, or pre-KAVA, and the severity of postoperative complication. It's time of ischemia. We have a median 22 minutes, and measure the blood loss, for example, when is major is less plus than 300 milliliters. 30% of the patient of this type of score was 0, without complication, without without injuries of vascular pedicle. 40% was the score 1 and 30 score 2. For the score to increase proportionality of the serious complication, we use this data as a ratio values. We know that we have PADUA score is very important. We do the score 2. The ramification of the pre-KAVA renal arteries, we do number 4 for the importance of the severity of the risk of the complication, and double weight to the pre-KAVA renal artery compared to other risk factors. Exit KAVA score, around 2, already mentioned for the PADUA score, pedicle ramification, artery and vein. For the 4 pre-KAVA arteries, double weight pre-KAVA renal artery score. The KAVA score has a minimum possible value equal to 6, and all other risk factors are null. There isn't a maximum possible value, but we can statistic to obtain very, very rare plus the 10, 12, or 30. Results of limitation. We use this type of score in 270 patients, and 109 have vascular variance, 40%. Compared with other studies, we have it already where was present 15 or 20 patients. We have it 109 patients. Extracellular renal arteries 31%. And the incidence of arterial venous vascular variance is more common on the right side. Statistic and anatomically described this type of ratio should be reversed, because in literature we have the frequency on left side. Clamping, do the lesion on the vascular endothelium. When we do the lesion, we have a ischemia, and the other aspect with clamping, reclamping of the arterial pedicle is the reperfusion phenomenon. After this, we have the results of oxygen-free radicals. The same, we do the ischemia of the vasoconstriction. We know with this type of score, the importance of the vascular variance of renal pedicle correlate with the anatomy of the tumor, describe the severity intra and post-operatively possible complication, provide the surgeon with more reliable approach of the renal unit. We have a limitation with this study because more than 40% of the patient, we saw it, the anatomic variance intraoperatory field. We don't have described with the radiologist before we do the surgery. We know that every time before do the surgery, we watch it to the CT or MRI to know exactly how many arteries and how many veins. But many times, the small branches, because it's less than 2-3 millimeters, we saw it intraoperatory. Probably depends on the clarity of the image on the CT on MRI. And a small number of study for this topic. One ischemia time is the important factor influencing the viability of the remaining kidney. As I already told you, that normal diameter of renal artery is 5.6 millimeters. This type of vascular variance are smaller. We do the microtrauma if less there, which is pro-inflammatory vasospastic substance. That's the result of the ischemia on irrigated areas. The same, the reperfusion phenomenon, clamping, reclamping with radical lever. We do the ischemia in the lesion of the parenchyma, and due to time needed to obtain surgical comfort, ischemic lesion grows. When you clamp the artery and you prepare other arteries or the tumor, the time is stacking, and after that the lesion and ischemic lesion grows. That's why it's very important to know before the start of surgery how many arteries and which one is the risk of this type of surgery. The risk of definitive ischemic lesion increased 3 times for a KAVA score above 9 and 5 times for a score above 11. KAVA score, we have equal and plus 11, risk of blood loss is more than 600. We already know that we start with 300, we have the already systemic change, but we have 600, it's a lot for the implication, especially an elderly patient with other pathologies. KAVA score direct alteration of renal function and requires a more detailed practical perioperative approach of the vascular capital of the arterial pedicle. Ischemia, haemorrhage, and anaemia are statistically significant for each factor taken separately in combination. The PADUA score already proved effective to our study group, and other studies is efficient to know the risk and the complication after the complexity of the surgery. And together with KAVA score, we know the probability of the risk and complication and their severity. Very important, the isolation careful dissection of the renal pedicle are performed much more easily by robot assisted, because we have the freedom degrees, we have augmentation, and is a faster learning curve for we do the safe surgery. Conservative surgery of the kidney is very important to avoid renal ischemia. That's why it's very important to know before the surgery the anatomy of the tumor and how many arteries are in the pedicle or which type of malformation. Selective arterial clamping, good knowledge of renal and also tumor vascularization. The duration of the surgery or operative difficulty is significantly increased. And the limitation of our study were the high number of patients, which the preoperative vascular components was not described in detail by the radiologist. Robotic assisted surgical approach is more efficient as a degree of liberty and 3D view. Is a technical challenge specific robotic assisted laparoscopic partial nephrectomy to prepare a avascular field for tumor excision, to do efficient hemostasis and shorter time order the preserved renal function. In all surgical specialties, urology is among the first that accepted and implemented minimally invasive therapy. We use today the robotic surgery in more than 85% of the pathology in urology. Our experience for sparing surgery, we start open surgery, and now we do it today. We have a complex tumor, but with helping with the robotic surgery, now more and more about kidney pathology, we can do it with minimally invasive approach. Open surgery, the same, the comorbidities associated because we cut the rib, we have the problem of nerve injuries and other lesion on the anatomical structure. That's why it's better to use minimally invasive approach. Isolation and careful dissection of the renal pedicle are performed much more easily. I already told you the degree of the freedom and provide the first learning curve for all the surgeons. And that's why it tends to be more commonly used. The KAVA score, the vascular capital of renal, is crucial for safe nephron-sparing surgery. Not only the vascular capital of renal pedicle generate intraoperative bleedings, after that the general complication. The incidence of vascular variance is increasing, maybe genetically is changed, maybe of the pollution or maybe there's elements. We don't know exactly why we changed that, why we need embryological study. Imaging procedure to monitor vascular details is very useful information for safe nephron-sparing surgery. Using KAVA score, an increased degree of safety guides stricter and more effective selection of candidates for nephron-sparing surgery, both functionally and oncologically. After that, we expect the pentafecta when you have a sure, very known that avoid the hemorrhagic, anemia, ischemia, and functionality and oncological results. Opens the perspective to further studies that are necessary to confirm this type of results. We need the studies of the relationship between the tumor-induced neuroangiogenesis cause of this type of hypervascularization, and multiple and multi-segment tumor vascularization are needed. Thank you.